Yeah, it's live now.
I'm just attaching the slides. Yeah, thank you. The slide is visible to all?
Yes, yes.
Mukherjee sir, slide is visible, sir, to you? Dr. Mukherjee, slide is visible, sir?
Hello.
Yes, sir. So you can hear me, sir? Dr. Mukherjee, you can hear me, sir? Just checking the mic.
Sir, I think you need to increase the volume of your speaker.
So participants are continuously joining.
Nobody. Yeah. Dr. Amarjit, meanwhile, you can start so that I can connecting with this Rupam.
So we can start the recording.
Hello.
Yeah, recording started.
No, তুমি এসো আমি স্ক্রিন অডিয়েন্সের সঙ্গে কথা বলার চেষ্টা করছি। হ্যালো। হ্যাঁ, ডান দিকের গলিতে। সামনে দিয়ে চলে এসো, রাস্তাটা একটু ব্যাকা মতন আছে। ওটা করেই ডান দিকে দেখো ডক্টর এস কে মুখার্জি বলে লেখা আছে, নীল রঙের বাড়ি করে তুমি গেটের সামনে এসো, গেট খুলে দিচ্ছে তোমাকে, ঠিক আছে? মাকে বলো একটু গেটটা খুলে দেবে, চলে আসবে। হ্যালো।
Dr. Mukherjee, could you hear me, sir?
হ্যালো।
Dr. Mukherjee, could you hear me, sir?
এসছো?
Dr. Mukherjee, could you start, sir?
ঢুকেছো? ও ঠিক আছে। হ্যাঁ চলে এসো, সোজা চলে এসো। না এবারে সোজা চলে এসো, রাস্তাটা বাঁদিকে একটু বেঁকা মতন রয়েছে, ওটা দিয়ে সোজা চলে এসো। তারপর ডান দিকে একটু, ডান দিকে সেকেন্ড বাড়িটা এসকে মুখার্জি লেখা, কোলাপসেবল গেটের ভেতরে একটা গাড়ি দাঁড়ানো আছে। হ্যাঁ 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 হ্যাঁ, গেটটা খুলে চলে এসো। বেলটা বাজাতে হবে না, আমি লোক পাঠিয়ে দিয়েছি। হ্যাঁ হ্যাঁ
Yes, sir, calling.
Good evening, sir. Are we audible to you?
কিছুতে কত অডিবল করা যাচ্ছে না। শোনা যাচ্ছে? তাহলে তাহলে আমি শুরু করে দেবো। ওকে ওকে ওকে। Thank you all the listeners of today's meeting. Actually, we are discussing about the best medicine of diabetes mellitus, that is insulin. You all know that insulin is supposed to be the best medicine of diabetes. And according to recent protocol of treatment,
Mukherjee, sir.
right from the
Can you-
day one,
Sir, can you listen to us, sir?
started in full swing, because HB1C should be controlled right from the beginning, and all the organs should be protected. And insulin is the mainstay of this blood sugar treatment in the case of diabetes. Insulin in pediatrics and type 1 diabetes, there is an increasing prevalence of diabetes in pediatric age group in India, and choosing the right insulin regimen is of utmost importance. So you have to use the right insulin in right place. And type 1 diabetes, we all know that type 1 diabetes should be treated with insulin. And insulin detimar, it is used in more than 1 year of age, and insulin gladitus more than 2 years, insulin glargine more than 6 years, insulin degludec for more than 1 year, and so on. This type of guidelines are there, that which insulin should be used in which age group. Insulin therapy in type 1 diabetes is a birthright of the patient. So traditional approach, short or rapid acting analog at each meal, basal insulin, OD or BD, dosing calculation, total daily dose 0.4 to 1 units per kg of body weight, and higher amounts are required during puberty, pregnancy, and medical illness. 0.5 units per kg per day is a typical starting dose in patients with type 1 diabetes who are metabolically stable. So 50% basal insulin and 50% bolus insulin divided between 3 rapid-acting injections. Calculations serves as starting point and should be adjusted according to patient-specific need. So type 1 diabetes should be treated with MDI or prandial and basal insulin আমি একটা ওয়েবিনারে আছি, আমি গাড়ি এসে গেছে, ঠিক আছে। So calculations serves as starting point and should be adjusted according to patient specific needs. Type 1 diabetes should be treated with MDI or prandial and basal insulin or continuous subcutaneous insulin monitoring. What is the role of pumps, insulin pump in type 1 diabetes therapy? That is continuous subcutaneous insulin infusion mimics the physiological insulin release from the healthy pancreas, delivers a continuous low basal infusion or rapid-acting insulin with additional bolus insulin and mealtime to cover prandial requirements and tailors basal insulin requirements to specific individual physiological needs. Continuous glucose monitoring helps in adjustment of dosage and thereby reduce overall incidence of hypoglycemia in diabetes management. And we all know that in diabetes, this hypoglycemia is a very dangerous sequence. So we must keep in our mind to keep the blood sugar in such a level that it should not be a hypoglycemia, should not be any attack of hypoglycemia. The second issue is in this discussion is insulin hepatic and renal impairment. So the patient, those who are coming to us with hepatic and renal impairment, the insulin metabolism is altered in chronic kidney disease. Insulin is stable, PK and low variability of dosage requirement with eGFR is preferred. So when the eGFR is low, the dosage of insulin also requires less. Newer insulin analogs like ISP, IDEC, IDEC-ASP, and faster aspart are safe and recommended in CKD with dosage adjustment. Glucose monitoring should be intensified and dose adjusted on an individual basis. Insulin in hepatic and renal impairment, we must be very much cautious as we know that all this insulin delivery system inside the body, in that situation, the liver and kidney are the main organ where from the insulin and neoglucogenesis occurs. The human mixture 30-70-50-50 renal impairment or hepatic impairment, insulin requirement may be reduced. Biphasic list flow 25-75-50-50 dose recommendation should be reduced. Insulin, degludec, liraglutide, IDEC-lira, this renal not to be used in end-stage renal disease and hepatic not recommended in severe hepatic impairment. Insulin, degludec, aspart, IDEC-ASP, no effect on PK properties. So glucose monitoring should be intensified and dose adjusted on an individual basis. RSSJ recommends use of insulin analog in type 2 diabetes with hepatic impairment due to low risk of hypoglycemia. Common insulin titration guideline in renal impairment is dosing and titration of insulin in CKD according to GFR. This GFR more than 60, no reduction, 60 to 15, 25% reduction, and less than 15, 15 is 50%. And GFR is more than 60 insulin doses unit per kg of body weight. Dose estimation of insulin in CKD according to the body weight, that is more than 60. Type 1 diabetes 0.5, 60 to 15 years 60 to 15 GFR, the insulin dosage 0.75, and in case of type 2 diabetes, 0.3 to 0.4. And GFR less than 15 in case of type 1 diabetes, 0.5, and in case of type 2 diabetes, 0.25. Newer analog insulin are metabolized by cell internalization, hence not majorly affected by renal parameters. The fourth indication of insulin, that is in pregnancy. Insulin in pregnancy is a very important and very useful chapter of today's discussion. That is SEOG, IDF, and DeepC. The insulin is often added according to SEOG, insulin is often added to nutrition therapy when fasting blood glucose level are persistently more than 95 milligram per deciliter, and 1 hour levels are persistently more or less 140 milligram per deciliter, and 2 hour level are persistently more than 120 milligram per deciliter. And IDF, this insulin is often added to nutrition therapy when fasting plasma glucose levels are persistently more than 90 milligram per deciliter, and 1 hour levels are persistently more than 140 milligram per deciliter. 2 hour levels are persistently more than 120 milligram per deciliter after 2 weeks of MNT and exercise. And DeepC guideline is that insulin is often added to nutrition therapy when fasting plasma glucose levels are persistently more than 90 milligram per deciliter. 1.5 hour PPG more than 120 after 2 weeks of MNT. Next is recommendations from RSSDI for insulin therapy in women with GDM. Pharmacological therapy should be initiated in women with GDM if they fail to achieve blood glucose target within 2 weeks of initiation of nutritional therapy and exercise. As insulin does not cross the placenta, it is the preferred agent in women with GDM. Insulin aspart and Lispro may be preferred over human insulin for better postprandial control. NPH or insulin detimar can be used for basal insulin requirement. This recommendations from RSSDI as insulin therapy in women with GDM. Am I audible, audience?
Yes, sir, you are audible.
Our next issue is recommendations for RSSDI for insulin therapy in pregnant women with pre-existing type 1 and type 2 diabetes. Recommendations from RSSDI for insulin therapy in pregnant women with pre-existing type 1 diabetes and type 2 diabetes. Insulin is considered more suitable over oral agent in women with pre-existing diabetes as they are unable to overcome the insulin resistance in type 2 diabetes mellitus, as well as cross the placenta and are ineffective in type 1 diabetes. An individualized insulin regime and glycemic targets by basal bolus injection therapy should be provided to every individual pregnant woman. Regular insulin or rapid-acting analog may be used in women with pre-existing diabetes to improve postprandial blood glucose. Women with type 1 diabetes and insulin-treated type 2 diabetes mellitus who receive antenatal corticosteroid to improve fetal lung maturation should follow a protocol that increases insulin, thus proactively to prevent hyperglycemia. Actually, there is one indication of giving steroid, which was not present in case of our regime. It is recently applied by the gynecologist. They use one steroid to the patient for the better lung function for the baby inside the womb. Dosing of insulin in pregnancy, that is RSSDI guideline, insulin dosing in pregnancy, weight-based dosing, and trimester plus weight-based dosing. Weight-based dosing 0.7 to 1 units per kg daily in divided dosage, and trimester plus weight-based dosing, first trimester TDD 0.7 units per kg, and second trimester thrice daily 0.8 units per kg, and third trimester thrice daily 0.9 to 1 units per kg. 50% as basal insulin at bedtime and 50% divided between 3 meals and given as rapid acting or regular insulin before meals. Insulin requirement usually fall during the first trimester and increase during the second and third trimester. Insulin during labor and postpartum, the moment baby parturites, so the dosing of insulin is also changes. During labor, to achieve target glycemic level, IV dextrose and insulin infusion during labor and birth for women with diabetes whose capillary plasma glucose is not maintained between 70 to 110 milligram per deciliter may be considered. And rapid-acting insulin analog like Aspart or Lispro are the preferred choice in achieving target glycemic value as they minimize the risk of hypoglycemia. And postpartum indication is that insulin requirement falls in the postpartum period by 34%, and that required in preconception period. Over the next 1 to 2 weeks of postpartum, the insulin requirement returns back to the required during preconception period. And during lactation, there is a sharp decline in the insulin requirement after delivery, and hence the dose of insulin needs to be adjusted accordingly. And this is a very crucial moment where the dosage of insulin should be very cautiously controlled, otherwise there is a chance of hypoglycemia. Now our next issue is insulin in elderly patients. So those are algorithm to simplify insulin regime for older patients. ADA has done it. So it should be done very cautiously as the older patients logarithm, the simplification of complex insulin therapy is been decided by a very complex slide. I'm not going through the details of it. The practical tips for management of elderly, it is assess functional independence and set appropriate and individualized glycemic goals accordingly. So there is no fixed dosage schedule, so it should be adjusted according to individual. Insulin chains with analog should be the choice whenever possible. I am coming regarding the Wockhart's beautiful MyPen 2 in details. After the deliberation, I'll tell you about the new pen, how beautiful it is. Basal only therapy must be used initially, in addition to rapid-acting insulin analog with the largest meal may be considered. Premix twice daily is convenient, but efficacy depends on regimented meals and lifestyle and not suitable in nursing homes. So it should be managed in house. Basal bolus therapy is ideal for busy individuals and offers the advantage of tailoring the rapid acting insulin dose according to the meal intake. The insulin requirement it becomes another important stage during our various pujas and fastings. So I'm just detailing about the main function of our country, that is Ramadan. This time there's a long fasting by the typical religious people, that is long-acting insulin once daily, first dose by 15 to 30% and take at iftar, and twice daily take usual morning dose and iftar, and one evening dose by 50% and take at sutar, and short-acting the normal dose at iftar and lunch dose at dinner, and one suhar dose by 50%. And mixed insulin once daily, take normal dose at iftar, twice daily, take half of the evening dose with suhar, and the usual morning dose with the iftar. Thrice daily, omit afternoon dose and adjust iftar and suhar dose. So in this case, this thrice daily dose should be converted into twice daily, and this amount of insulin should be divided in morning and afternoon dose. So there are lots of fasting ceremonies throughout India as there, and there are several separate indications and modus operandi. But one thing that this classification mainly depends upon the purchase capability of the patient, because these various types of insulin, better insulins are bit costlier than the normal insulin. So we have to see whether the patient can purchase the better insulin. So our dose flexibility becomes much more easier. And regarding the pen which I was telling, that is a very beautiful pen that is called My Pen 2. There's a new pen regarding this of this Wockhardt for this insulin delivery system. The pen is much more lighter than the previous one. Pen is much slim than the previous one. The dialing system is also makes one sound that is very much useful for the older and poor visibility those patients are having for those. And dose adjustment is very much accurate. So if the pen is given by the Wockhardt company, then that is gifted to the patient. Otherwise, it costs round about 800 rupees if you purchase it from the shop. That is also cheaper than the other companies' pen. So our key message is that in management of diabetes, in the pre-diabetic, in pediatric age group, and basal bolus regime remains to the gold standard. So there should be no change. Basal insulin analogs that offer the advantages of lower hypoglycemia with minimal glycemic variability, in addition to dosing flexibility, should be preferred in pediatric patients, and bolus insulin analogs that offer the advantage of insulin dosing with meal flexibility should be preferred. Glucose monitoring should be intensified, and dose adjustment on an individual basis in renal and hepatic impairment. In this, from my own experience, I can tell you that this SMBG, that is self-monitoring of blood glucose, is a must. You have to teach the patient how to do it, because there are health educators also that is provided by company. These health educators, they attend the patient's house and they teach them, because if they teach this SMBG, then adjustment of insulin dosage is becomes very easier, and chance of hypoglycemia will be also less. It is recommended to use insulin analog for management of type 2 diabetes in patients with renal and hepatic impairment due to low risk of hypoglycemia. I've already said that liver and kidney, when these two organs are damaged by this type 2 diabetes, so dosage of dosage of insulin becomes less, so chance of hypoglycemia is more. So we have to treat it very cautiously. Dexterity and fertility and comorbidities, multiple medications are key challenges faced by elderly people with diabetes. Newer insulin delivery device and insulin analog offering simplicity and convenience should be preferred. Insulin analog with proven lower risk of hypoglycemia should be preferred in people with diabetes intending to fast. So during this fasting, this dosage adjustment is also very much important. Over and above, not only medicine can cure, make the patients safe or euglycemic. Lifestyle modification, including physical activity, nutrition plan, pre-fast counseling, and structured diabetic education plan should be ensured, along with appropriate dosing and titration of medications. Last but not the least, which I have experienced from my practical life, that here insulin, just in the onset of my speech, I've told you the insulin is supposed to be the best medicine of diabetes. There is no alteration, but patients are having some needle fear. So we have to do it, and we have to understand the patient that there is a difference of needles during ordinary injection and insulin pen injection. So there are several doctors, even I used to do it just in front of patient. You have to practice. If you can show the patient by practical demonstration, patient will get much more confidence, because there are several conditions where oral hypoglycemic agent cannot control blood sugar, cannot control HbA1c. So organ protection. So according to latest indication of diabetic treatment, as we all know, that right from the first day we have to treat the patient. So we must keep in mind, if it is needed, then right from the day 0, we can start insulin in their treatment. Thank you for your patience hearing, and thank you, Wockhardt, because due to this problem, which I am not at all quite at home regarding this computer and all these things, I forgot. I couldn't give the thanks to the Wockhardt pharmaceutical companies and the persons, those who are listening my lecture with their patients. Thank you and good night. Have a good, very prosperous puja, which is very soon coming. Thank you.
Thank you, Dr. Mukherjee, for your remarkable and wonderful presentation. So we will request to audience, if they have any query, they can ask to sir. We will just wait for 1 minute if any query is there. Otherwise, we will go for vote of thanks. So Vishwa, it is over to you. If any query is there, otherwise vote of thanks. Thank you.
Okay. So thank you, Dr. Amrit.
Question, query, you can ask.
Yeah. I request audience to please post your questions if you have. All right. I think we don't have any questions here, so no worries. Yeah. So I have two great news to share with you. First is that Wockhardt has completed 20 years. In 2003, we launched Wockhardt and put India on the global map of insulin manufacturers. And India became the third country who started producing own insulin after US and Europe. So I would like to thank all the doctors and the medical fraternity for this, for making Wockhardt achieving this milestone. So thank you very much. And second is, sir, that now we are having a new masterpiece, a world-class My Pen 2. And for the audience benefit, I would like to
Hello.
share a video with all of yeah, sir. So I
Please
would
go
like to
ahead.
share a video with all of you, so which will depict the benefits of My Pen 2. So I hope the sound is clear with you all. Yeah. So this is the video.
Good quality insulin pen, which is intuitive in nature and easy to use, plays an important role in insulin initiation, adherence, and better patient outcomes. Addressing these needs, Wockhardt proudly presents MyPen 2, which is designed in Europe as per ISO 11608 standards. The salient features of MyPen 2 are improved design. MyPen 2 is sleek with a soft touch cap and smooth finish body. MyPen 2 has a twist lock cartridge cover for ease of replacing insulin cartridge. The dose delivery is smooth and easy, ensuring less pain and discomfort. Loud and audible click sound in MyPen 2 ensures error-free dose delivery. Easy to use. MyPen 2 is easy to set, easy to read, and easy to inject insulin device. Its light, sturdy, round, non-slip body ensures maximum grip, which helps in smooth administration of dose with confidence and convenience. Usability features of MyPen 2 like low force to inject and easy cartridge replacement ensures better acceptance by all age group of patients. Accurate. MyPen 2 is designed in Europe as per ISO 11608 standard and manufactured in India as per ISO 13485 standard. MyPen 2 shows excellent dosing accuracy at all dosage levels. Even the injection force is comparable with best-in-class devices. MyPen 2 can be used with Claritas and Wockhardt range of cartridges. Doctor, kindly pass on the advantage of improved, easy to use and accurate MyPen 2 to all the patients on Claritas and Wockhardt.
So this is the world-class My Pen 2 that we have introduced recently, and our team will be visiting you to give the demo of the My Pen 2. So thank you very much, sir, and thank you very much, Dr. S.K. Mukherjee, sir, for the very insightful session. And I thanks all the audience to connect with us through this webinar. And I thank Dr. Amarjeet Singh, Dr. Kunal Srivastava, and Dr. Sanket Nevale for scientifically powering this iTrust webinar. And my gratitude towards our IB president, Mr. Amrit Medekar, and Mr. LCS Sri Vishnu sir, who is our cluster head, for their guidance. And my field team, who has worked very hard to organize this iTrust webinar. So thank you very much, everyone, once again, and we are signing off. Thank you so much.
Thank you. Thank you to all.
Thank you, sir.